Welcome to another session of surgical pathology, slide review, and digital sign out. Today we're going to continue our series looking at pancreatic pathology. Our case is that of a 58-year-old man who experienced renal colic and on further investigation was found to have a cystic mass in the tail of the pancreas. We have a representative CT image of this patient's abdomen, and we can see right here in the distal portion of the tail of the pancreas a somewhat complex cystic mass with varying densities located in the tail of the pancreas. Radiographic measurement was of about 3.5 centimeters. Now there would be a couple of ways to approach this. One would be by means of endoscopic ultrasound and needle aspiration, which would yield diagnostic material, as well as in complicated situations, surgical resection. Since this is a discussion of surgical pathology, we're going to go to the surgical specimen rather than focus on the cytologic findings, which also can be quite characteristic in this particular entity. Here we see a section, whole mount section, showing a peripheral margin of a lesion, somewhat complex structure with a mixture of blue areas and less cellular, maybe necrotic or paucicellular areas. If we increase the magnification here, we'll see that there appears to be a lymphoid stroma as well as an epithelial lining and then some material in the center. Now on higher magnification of this material, we see that it has sort of a basket weave or structural characteristics similar to that of keratin. And not surprisingly, the lining epithelium is also keratinaceous producing squamous epithelium with even in some areas a granular layer. Here a little bit further, we see here the granular layer even quite nicely developed here at the juncture of the cyst contents and the epithelium. Now this stroma surrounding it is obviously lymphoid tissue with even areas of germinal center formation and variable amounts of fibrous tissue. This is true throughout the lesion. We will see some areas with degenerative changes, such as here, some cholesterol clefts and foreign body giant cells. Here are a few cholesterol clefts in the keratinaceous material, indicating that there's occasional disruption and reaction and degenerative changes that occur in the process of growth of this lesion. Cytologically, in no areas does the squamous epithelium appear particularly atypical. Nucleoli, when they're present, are very small. Nuclear membranes are smooth. And the chromatin is not particularly pronounced. Atypical mitoses or other features of malignancy are not identified. So this is a lesion that is very aptly termed lymphoepithelial cyst. Typically this lesion occurs in the tail of the pancreas. It's not a very common lesion. But it can be a source of concern and occasionally can cause symptoms, as you see, as it grows or creates a mass effect or as there's an inflammatory reaction to the process that can become more symptomatic for the patient. Simple removal is certainly adequate, but not required, especially if the diagnosis has been rendered and the symptoms can be attributed to other causes. So our final diagnosis in this case is lymphoepithelial cyst of the pancreas. It's unclear what the etiology of these lesions is, whether they represent uh, vestigial rests from the embryologic stage, whether they may be isolated foci of splenic tissue that somehow entrap epithelium and develop. They typically are present in this location, sometimes also could be seen associated with pancreatic, or excuse me, with splenules and so forth. But be that as it may, it's a lesion which generally has a benign behavior and only becomes symptomatic if it becomes damaged or enlarged for some other secondary cause. So thanks again for joining us today for this case in the nuances of the pancreatic pathology, and we'll look forward to joining you next time.